Obviously, like I mentioned in the beginning, whether you have a prostate or love someone who does, it's important. It's an important topic because everyone knows that a man, and this is the main disease that really affects men besides heart disease, is some disease with their prostate, whether an enlarged prostate that causes men to have urinary symptoms that show up later in life. For men, it's maybe the postmenopausal equivalent of diseases that pop up after 50. And they can also develop cancer of the prostate. And so that while that can be oftentimes treated in a very easy or simple type fashion, it also can be a situation in which where everyone gets scared, and they can be scared because they get certain laboratory results like a PSA test by way of example, and you don't really know how to handle it. So whether you're actually the patient itself, and maybe half the people in this room are what I'd consider the patient or potential patients, and then half are what I would consider allies. It's a real big thing in our company. Like you mentioned, Jill, about our national company of prostate centers is, delivering healthcare is not always through just the eyes of the person who's actually going through the stressful moment, the disease themselves, et cetera. It's really the surrounding cohort that's around them. And that group around them is what really determines, honestly, the outcome of how we all do. So when you're with somebody, and this is the first thing I would say, is this is really for the group of folks who are on this meeting and joining, who potentially are in the ally role, for example. For those individuals, oftentimes people don't talk about their prostate, and men, of course, never really want to talk about their healthcare in general. They're probably not as open and are not used to seeing physicians from such a young age, at least from 18 to say 50. And it's oftentimes important for allies to say, hey, have you gotten this checked? Have you gotten your prostate checked? And not potentially changing the subject when things come up. And there are parallels that both women and men go through that are really important with respect to urinary frequency as we all get older. And knowing these symptoms of what to look out for and what to talk about, I would say in terms of importance, these are really important things. So before we get into prostate health, in medicine, there's always this funny analogy that all physicians and healthcare providers make is all organs and things for some reason are always compared to fruits, nuts, any sort of dietary thing. I'm not quite sure why, but for the prostate, and you know what it does, it really sits below the bladder. It's really just a passageway by which urine flows from the bladder and out through the penis. It's normally about the size of a walnut. So to give you an idea of what size of a walnut, you guys all know what that is. We say a walnut is probably 25 grams or 25 cc's. And so what this organ does, or the prostate, because the urine passes through it, it wraps around it. So imagine if you took an apple and you had to core an apple and you poured water through the middle of that apple. Well, water would go through really well. But if the apple starts to grow and get really big or whatnot, or irritated, it's going to press on that urethral lining, which is the lining where the urine will go through. And that's why men get a lot of the symptoms that they get. Prostate also makes this supportive fluid that supports the sperm, which allows for increased opportunity for fertility, although it doesn't make the actual sperm that leads to fertilization and pregnancy. So unfortunately, we like to think about the prostate as physicians. We think it's kind of like a plumbing flaw because it grows in your life whether you like it or not. You cannot necessarily on your own directly control the growth of the prostate, but it will grow whether you like it or not. So it'll continue to grow over time. And then that design flaw is that it will impact the urethra and the passage of that urine. The two big things to know about the prostate, which I'm sure everybody knows that I'm going to cover today, is one is a non-cancerous condition called BPH, or benign prostatic hyperplasia. And that's where the prostate just gets big. And the other is prostate cancer, which is what we worry about, of these uncontrolled cells that could grow and then ultimately spread. Now, BPH, or the enlarged prostate, is so common, it really affects almost every man. And a good statistic that we tell our patients is about 50% of men at 50 have BPH and 80% of men at 80 have BPH. So it's really, if you live long enough, you probably will get an enlarged prostate. it does not predispose to cancer risk. It's not cancer itself. And it's really more of a quality of life issue at the beginning. Men who have to frequently go to the bathroom, they go play golf and they can't make it to the ninth hole to use the clubhouse to go to the bathroom. They have a slow stream. They get up at night. When they park places, they usually try and park near a bathroom so they can get to a bathroom. And at early stages or moderate stages, it's very easily treatable. Later stages, this enlarged prostate, because it's blocking the urine so much, unfortunately causes other issues where it can cause complete blockage of the urine. It can cause bladder stones, urinary tract infections. But the goal really here with good prostatic health is to avoid that and recognize those symptoms early. Prostate cancer, to completely differentiate, although it has a very high survival rate, meaning patients do very well, even if they're diagnosed with prostate cancer because of good screening. The key here is screening, is that men who undergo screening, even if they're unfortunate enough to get prostate cancer, can do very well from the treatments that are there. So when you take a step back and go, well, how do I actually avoid these things? What's the best way I can practice the best form of wellness for myself? It's really think about this way. Whatever is good for your heart is actually good for your prostate. And it has less to do with, say, okay, I'm eating certain things that may increase my risk of heart disease. Unfortunately, the same components that are part of food are also hormonal in the sense that they can stimulate prostatic growth. And so when we think of those men who are on high fat diets, lots of saturated fats, for example, those fats unfortunately cause hormonal changes that can lead to accelerated prostatic cellular growth. So that just means the prostate cells grow faster and you are at risk for getting a larger prostate. So when you think about healthier diets, loading up on plants, vegetables, legumes, whole grains, for example, utilizing things that are omega-3 rich. Obviously, people like, and not everyone, but many people like to eat meats and or red meats. So if those meals can sometimes be substituted for fish, for example, or a Mediterranean type style diet, that's actually much better for you. Exercise is really interesting. It's kind of a double-edged sword. Exercise is one of those things where if your exercise does not involve bike riding, or bike riding may be the only exercise which can aggravate the prostate in terms of if it's long distance bike riding, all other exercise, for example, doesn't necessarily have that effect and is very beneficial. So when we look at what statistics show, if those who use exercise regularly, and it doesn't have to be high intensity exercise. By way of example, the most recommended routine we give patients is walk 2 miles a day. If you can walk 2 miles a day and spend that 30 to 40 minutes walking every day, it doesn't have to be an incline, doesn't have to be at a high pace, but if you can walk, that repetitive behavior, and that's easy to replicate, is going to lead to healthier weight, better hormonal balance, fewer BPH related symptoms. And if you ultimately need treatment, it's one thing people don't often think about. When you undergo a treatment, your outcomes from that treatment are also much better if you're in much better overall physical shape. And so this can reduce the risk of prostate cancer statistically. It can also reduce the risk of having a greater enlarged prostate or BPH, a non-cancerous condition of BPH. But last, and what might be important in the rare circumstances, if again, you're unfortunate to have to treat these conditions, you'll likely have a better outcome. And so that's really important. So this is the one thing that I think when people think about prostate, and at least I do, because if you've ever spent a late night sitting on the couch watching TV and you have to watch one of those 60-second commercials that come up, it's a million things that come up, right? And everything comes up and says prostate beta health, prostate vitamins. Are you getting up at night? I mean, it's a great time to put commercials on because that's probably when people are getting up at night to use the bathroom. But suffice it to say, this is the real evidence. The real evidence, and this is what I tell my patients, and I'll show you a procedure that I developed 17 years ago that's utilized all around America to treat men with enlarged prostate. And I have men who come to me and say, oh, I take lycopene and I take saw palmetto and I use some of these different vitamins. And I'll turn around and I'll say, this is what the data shows. Lycopenes or tomatoes, for example, have some mixed results. Saw palmetto in the largest double-blind randomized placebo-controlled studies, for example, have not proven any benefit. There are men who take them, and what they often find is when they're taking them, they often take them at different times of day, change when they take their fluid intake, and then they find a secondary benefit. but it's not been proven out. And when you see commercials or when you see not just advertisements, but if you're in a vitamin store, a health food store, or Whole Foods, for example, and you see these prostate formula blends, put them down and save your money. They are not associated with any improvements at all. It's difficult to probably think about why for some folks, but I will tell you that where supplements may help you in certain conditions, like whether it's related to dementia prevention or whether it's related to nutritional deficiencies with certain diets, those are well established. With prostate health, I would say take the vitamins and leave them on the shelf. I would say this is something that people don't realize. Now, it may not apply to all the allies, but it'll apply to the men. The largest and well-conducted studies found an association between higher ejaculation frequency and lower risk of prostate cancer. This is borne out in men who have more frequent sexual activity and in self-stimulation. And so I know it's not something we often think about is like, hey, can I actually do something that has been associated with improved prostatic health? But in terms of science, this is one thing where I'd say sometimes when you deliver the unexpected good news, it's actually good news for everybody. And so it's not necessarily a prescription and advice, but I will tell you there's a strong association between that. Okay. So now let's look, we're going to first look at prostate cancer, and then we're going to look at what enlarged prostate, and we'll talk through what I think are probably the most important things and questions that men have asked me over the last 20 years, and men's wives, spouses, family, for example, is, why did I get this? What could be done to prevent it? What are the potential treatment options? What are the tests? I'm really worried about this blood test I got. What do I really need to do about this? Do I even need to get prostate cancer screening? Because the guidelines change from time to time, and my one doctor tells me to get it. My other doctor says it's not important. So I'm going to try and go through some of these statistics. Okay. So 1 in 8 men have a lifetime risk of being diagnosed with prostate cancer. I will tell you, if you look at men who die and then you look at autopsy specimens, it's actually much more than that in terms of men who actually have prostate cancer, but it may have not been necessarily diagnosed. Okay. The overall survival rate at 5 years is 99%, which is very high. That means from the time someone's diagnosed to the time that at 5 years, at that 5-year interval, how many will still be alive? And it's 99%. So it's very high. Now, some would say, well, 5 years is not enough. What's your 10 and 15-year survival? Then it starts to depend upon the stage at which you're diagnosed, meaning early stage, intermediate stages, or later stages. And this becomes the most important thing for why screening is so important. And blood tests are really the way to go in terms of getting your first PSA. And I'll talk a little bit about that too. It is overall the second most common cancer in American men. And the goal of screening is really to catch the dangerous ones. What men often realize when they actually get first diagnosed with prostate cancer, and this is a large group of men, is when they get diagnosed, oftentimes it's just followed and they're not actually put under any treatment. And that can oftentimes be scary. And people are like, well, why am I not getting chemotherapy or my prostate cut out or radiation or some sort of immunotherapy or gamma knife? And the real reason is because those treatments don't actually extend your survival in very early stage and very low grade, meaning a non-aggressive type. And so oftentimes men can just be followed with imaging and blood tests over many years. And if they need treatment, they can get it, but they're not at worse risk. They're actually at worse risk in those early stages or low grades of having a complication of the treatment. So they shouldn't be afraid of getting diagnosed, because oftentimes we don't want to treat somebody unless we have to, because those treatments may cause an increased risk of complication. So when we talk about screening, this is kind of the analogy. Screening is like a smoke detector. Okay. It's not really the fire. It just tells you to look around, not to panic, and really figure out what to do. That's how I look at screening tests. And that's how patients, I wish, could across the board look at screening tests. So it's not that the PSA tells you I definitively have cancer. So when men get a PSA, what a PSA is, it's a hormone that's released from cells that are within the prostate, not just cancer cells, even non-cancerous cells. And so if you have an enlarged prostate that's non-cancerous, you may have an elevated PSA. If you have cancer, your PSA may be more elevated than it should be for that size prostate, or it may be rising faster, for example, than it should be as you just get older and your prostate gets larger. So it's worth a closer look. There are then a number of other tests that go beyond this that say, okay, should I do something if I have an elevated PSA? And this is the one, I think, important slide if you're, especially if you're a man or a family member, ally of somebody else's. If you get a PSA, everyone goes to their doctor and they get this as a screening test. And the doctor says, okay, or they look at their own test. And the high end of normal is 4. And if the blood test comes back 4.2, 4.8, 5.6, everyone panics. And they go, I got prostate cancer. And first, the most important thing is say, well, did something stimulate this? Did I have a recent urinary tract infection? Have I been retaining urine a little bit more than I usually have and holding it, not going to the bathroom? That could irritate the prostate. Did I even ejaculate before this PSA test? That can cause the prostate to be elevated. I could just have a large prostate, or like we talked about with exercise, you could have been doing a bike ride and you could have been doing a HIIT exercise. You've been in Orange Theory and been like, okay, I'm on the rower and I'm a man and this is affecting, or I'm on the bike instead of like say the tread, and you're in a situation where you're like, I'm actually getting my prostate irritated, and that can cause the hormone to really elevate. So the first thing oftentimes is repeating the test. The second thing might be actually looking for a trend. We want to see over a period of time that this PSA is going up. We don't necessarily want to just see one test. Now, if you're the kind of person or a man who's never been to a doctor's office, or you're taking your husband or boyfriend, whoever, significant other, to a doctor's office and they've never gotten a PSA and the first one's at 70, that would be a different consideration. But if what we're looking for is on your annual exams and you're getting your PSA, that is there a trend of this increasing? There are drugs that can reduce it. So if you take Propecia, for example, for hair loss, those drugs can actually halve your PSA. So you want the doctor to interpret it with those things in consideration before you say, okay, I'm just going to get a biopsy because I think I have prostate cancer and that's the case. Even if you think that's the case, you also may want to get an MRI, which in here is after you get these refined tests. So there are all sorts of refined tests, 4K scores, PHI scores, select MD scores. These are other laboratory tests that laboratory companies have designed to be more specific for prostate cancer. And you don't start with them because they may be a little bit more expensive. Your insurance may or may not cover them. And they're only good when you have an elevated PSA. So if that becomes abnormal, then you may want to get a prostate MRI. Why do we get imaging? Well, if you have a prostate and you need to sample it with a biopsy where you put a needle in and take samples, the MRI can tell you where to sample. So you're not just sampling the whole prostate, which is what traditionally has happened in urology or urologic medicine for the last 50 to 60 years, which is just put a needle in the prostate, take 12 samples or 18 samples like a clock, and just go around the clock at 1 o'clock, 2 o'clock, 3 o'clock, take a piece of tissue, and hopefully you get where the cells are because you've gotten a good sampling of the prostate. Nowadays, targeted biopsies, and that's something that's important to know, is something that you should be thinking about, okay? So all in all, who should get the screening and what's important? The conversation should really be started at 45. Every 2 years, so the current guidelines between the ages of 50 and 69. And we tend to wind down at 70, 75 based on health status. If you think someone's going to live and they're overall healthy till 90, continue to get their testing. If they're otherwise have many other medical conditions, some people and primary care doctors will say, you know what, I'm not going to bother diagnosing this because we're not going to go through treatment anyways. And that's something that you should be part of that decision. Now, if you're a higher risk patient like I am, so I'm a higher risk patient. My father had prostate cancer, and so I have a first-degree family history of prostate cancer. And what you want to look at is you want to look at the age that they were diagnosed and start screening 10 years earlier or at this same time at 45. So for me, for example, I started screening at the age of 40. And so I was like, you know what? There's no harm in getting that blood test 5 years earlier than I want to. And it's important to get that earlier and just say, listen, I'm going to get it. Now, you still could stick to this every 2 years, but the point is family history. If you're African-American, it's important that you get this as well because there's a greater risk in men who've had either a family history, or they're African-American. So if you're the ally, if you're the friend of the family, if you're the spouse, it's important to not just ask in those questions. hey, have you been getting your prostate screening? Like women are used to getting their mammograms, for example, and pap smears. Men, they're not used to that, right? So as soon as someone tells them go get their prostate checked, the first thing they look at you is like putting their finger in the air and they're saying, I'm not getting there done. And this has nothing to do with getting a rectal exam. It all has to do with getting a blood test. And so they should be getting it. And from your perspective, the nice thing to potentially add as an ally to making sure that you're educating them is that, listen, it's not just getting the test, but did you consider, do you have a family member? Did you let your doctor know that you're a family member? Oh, by the way, you're also African American. You may want to consider getting this 5 years before everybody else. And that's the best way you can convey, whether it's friends, family, colleagues, that you should be getting their surveillance. That is the most important thing that they get, or screening. From a surveillance standpoint, if it's found that you have surgery, like I mentioned earlier, many of these patients go on active surveillance, which is what we call it. If you do need surgery, there's so many options nowadays, from getting a prostatectomy, which is getting it removed, radiation, there's multiple types, brachytherapy, which is where we put radiation seeds into the prostate. And then there's even these focal therapies where we just try and freeze or electrocute or ultrasound energy kill a tumor, but not try and treat the entire prostate. The key is when you have early detection, you can do less later to get the same cure rates. And that's the key. Okay. As far as an enlarged prostate, and let's pivot to this. And after we finish this, I'll definitely go into the chat room and we can talk and ask questions. And obviously, you guys can ask them verbally in addition to the chat area. But what does it mean when you just have an enlarged prostate and it's non-cancerous? Okay. So if you have an enlarged prostate, it's really like aging of the prostate, meaning it's getting larger. It causes men to start and stop their stream. So they go, they stop, they then go to the bathroom, and then they kind of have to go right back to the bathroom to empty. They have to go urgently or frequently, so they can't hold their urine oftentimes for more than 2 to 3 hours. Usually first signs of this are men who start drinking coffee, and then within an hour, they're like, I already got to go to the bathroom. They're not urinating a lot of volume, but they just have to go because the prostate's irritated. They don't feel like they've emptied, so they have incomplete emptying, and they feel like they have to go back to the bathroom oftentimes, and they get up at night to go to the bathroom. Now, the key about getting up at night is this. Always remember that women get up at night to go to the bathroom too. It doesn't mean, obviously, they don't have a prostate. We all get up at night to go to the bathroom, most typically because of dietary reasons. We're drinking either too late, alcoholic beverages, taking medications at nighttime that they need to, diuretic type foods, for example, caffeinated beverages, for example, at nighttime. And that was what makes people get up at night. The other thing that most people forget about is that sleep quality makes people get up at night. So if you've ever been in that situation where you get up and everyone stared at the ceiling and they're like, get up, and they're like, I have to go to the bathroom. Not a lot, just a little bit. Nobody wants to close their eyes and get back to the bathroom. So men are classic examples of this. They snore, they have sleep apnea, they don't get great good sleep quality as they get older. So oftentimes half of their nighttime urination is actually not the prostate. It's between dietary, medications, and poor sleep quality. And so when a man tells me I get up at night 4 to 5 times to go to the bathroom, I usually can attribute about half of it, meaning 2 times are probably just because you have poor sleep quality and or dietary related considerations. The other 2 times are probably truly related to your prostate. So keep that in mind, but that's one of the most common complaints. And honestly, it leads to a lot of daytime sleepiness for men. They want to have naps. They're not real productive. It's outside your normal afternoon melatonin changes that lead to everybody having like tea time, coffee time, et cetera, to get a pick me up. These are just men who are really tired by even 11 a.m. And so it's very important because it can interfere with their lifestyle and work. The real rule is if you have an enlarged prostate, you don't necessarily need to do something. When it bothers you, it's probably worth talking to someone about it. And there's really no prize for toughing it out. So the longer you tough it out, honestly, the more at risk you're putting your bladder under potentially having a longer term complication. Your bladder can have complications from holding your urine too long, stretching out, getting thin, not being as strong as it needs to be. So if you notice this also in someone in your life, please bring it up. You can give them tips about the sleep quality, give them tips about how they can adjust their fluids, caffeine, alcohol intake, for example, but encourage them to talk to somebody about it. They could ironically be going to the same urologist or primary care doc, for example, that also, can screen them for prostate cancer. And they've been scared because they're afraid of the potential treatment options. The treatment options for an enlarged prostate have evolved a lot over the last 20 years. Typically, there were medications. Alpha blockers are medications that just relax the prostate. So that example I gave you of the apple coring, where you core the apple and the urine goes through the middle and now it's too tight, it just relaxes the tissue of the prostate. It reduces symptoms a little bit, maybe 10%, maybe 15 in some men. Alpha blockers are not, 5-alpha reductase inhibitors. They're hormonal medications. Those hormonal medications actually work to reduce the size of the prostate. They take a long time to work, but they can reduce the symptoms in the prostate also around about 10%. And then there are these newer medications that were utilized for erectile dysfunction or for men who can't get an erection, like Cialis. And at lower doses, they've been shown to actually improve symptoms from enlarged prostate. What I like about these medications, they've actually been shown to increase mentation, meaning a man's ability to actually have better mentation has actually been shown with Cialis as well. And so I like the fact that they have neurologic side effects that are also improved. Where the first two medications, for example, alpha blockers and the hormonal medications, they have a lot of side effects. Everything from stuffy nose to lightheadedness to breast enlargement in men to fatigue to ejaculatory problems. So my point is, medications are oftentimes not popular amongst men because they can work to a degree, but they do carry some significant side effects. There are lots of minimally invasive procedures. I have some videos in here. UroLift is like a staple procedure to open the prostate. These are things to avoid having, like a rotor-rooter, which is what everyone's heard about, called a TURP. And that has a lot of side effects. And most men, of course, don't want to have that because it requires putting a catheter in the penis. So UroLift is a clip procedure where you put implants in. And I'll show you these on the next slide. Rezum uses steam to kind of destroy the prostate tissue. Aquablation is, if you can imagine, like your pressure hose that you use to clean, pressure washer to clean your driveway, for example. And PA is this procedure that I developed 17 years ago where you shrink the prostate by not even going through the penis to reduce the blood flow to the prostate. And so in the top left is a UroLift procedure. And this is where, again, a urologist goes through the penis, puts the scope in and puts these little clips. You see those two staples with a suture or stitch. What that does is it tense open the prostate. It's minimally invasive because it doesn't cause a lot of ejaculatory or erectile problems. It could be done in the office or a surgical center. The problem with this, as you can imagine from the illustration, is the tissue doesn't move like that so easily, and the tissue likes to grow around those clips. And so it works, but it fails a lot. It has about a 30% failure rate by 2 years. And the next procedure is Rezum. It's a steam procedure. And so, again, a catheter is put in through the penis, and it emits steam, and it destroys this tissue on the inner lining of the urethra. So you imagine that cored apple example. This is exactly what this is doing. You're putting the core in, but instead it's heating the inside of the apple, and now that tissue gets destroyed and through vapor, and then basically it can widen that channel. And it's done at different portions of the prostate to try and enlarge the channel. Again, it kind of has a higher failure rate, just like UroLift, but it can avoid some of the complications. In the bottom right, sorry for the graphic animation, this is reality of healthcare. What happens is the water jet procedure is a procedure where an ultrasound is placed in the rectum, and then the water jet is placed through the penis. I can already see people probably thinking to themselves, why is this considered minimally invasive? It's not really, but it's less invasive than the typical surgical options. And a water jet is actually put in, as you'll see here in the bottom right slide. This water jet's like a window washer, and it basically, it destroys this tissue. The good about it is it works really well because it's high pressure water. The bad about it is it has a high bleeding risk because it doesn't use heat. And things that don't use heat can't cause blood clots. And because it can't cause blood clots, there can be a significant amount of bleeding associated with the procedure. It's called Aquablation. It's come on the market in the last 5 to 6 years. It is very popular, and I just bring it up so you guys can see what different options are. This is the procedure I developed because my procedure overlaps with vascular. So as an interventional radiologist, I use imaging and I put catheters and wires into people's arteries, and I use almost like a video game technology through an X-ray machine to drive catheters through the body. And so we developed this procedure many years ago, running the first U.S. clinical trial and subsequently many after, where we put a catheter like this through the arteries. We drive a small catheter. It's about 0.6 millimeters in size, so very tiny, into the arteries that go to the prostate. And then we deliver these little microscopic spheres. It's like grains of sand, smaller than that, actually. They're about 100 to 200 micron in size. Those spheres deprive the prostate of blood flow. the prostate needs more blood flow because it's enlarged. Well, we reverse that, and then what happens is the prostate shrinks. So on the right is actually a prostate, which is an explant from an animal lab study, where that's the prostate on the left before and what the prostate would look like after, where it's, shrunken by 30 or 50% of the size. And that allows the prostate to have less pressure on the urethra or the passage of urine. Honestly, men love this procedure because nothing goes through their penis. It doesn't have any effect on erectile or ejaculatory function, and it can really work in any man. It doesn't improve the flow as much as the traditional surgery, which is called TURP. And TURP is the gold standard. And we call it the gold standard because it's been around forever. It doesn't mean that EA, or the last procedure I showed you, doesn't have clinical studies against it. It actually has 7 randomized control studies against TURP, but TURP has been around forever and it gives probably the best flow rates. It doesn't mean that it gives the best surgical outcomes in terms of overall quality of life, complications, etc. But I show you this so you know that this is a stair step. When you have a condition where it doesn't have to be treated, you don't want to run to the top of the stairs like Rocky. I mean, you want to go into this and you want to actually go in and say, hey, listen, what can I get that's less invasive? What can I get that protects my bladder health? What can I do to really help my overall health without having to necessarily go through a risky surgery? So I call this sort of like your Monday morning playbook, right? If you have a prostate, get your PSA, start your baseline in the 40s. Screening at the right age for cancer is most important. If you unfortunately have a high PSA, don't panic or suffer in silence. Hopefully what I've explained can tell you there's lots of steps to figure out, is it really real from the beginning? Okay. If you're supporting someone, learn about people. What's their family history? Have a conversation. If you're a woman where you're used to getting things that you probably don't talk to men who are friends, et cetera, about, like, oh, I got to go get my mammogram, then I got to get my tomo, then I got to get my biopsy, then I got to get my ultrasound, then I got to get my biopsy again. Women are used to this. Men are not. And so when you're an ally of someone, I think it's really important to bring up that conversation. If you need trusted resources, I would say certainly with all the misinformation that's out there, do not get your healthcare through Instagram. While I'm a subscriber of Instagram, I certainly, maybe because I'm a physician, I get more vitamin ads than anybody. I will tell you, get it from trusted sources. urologyhealth.org, NCI, Cleveland Clinic is a great source. Our society, which is the Society of Interventional Radiology, even the American Urologic Association has great resources. Compare resources. And so I want you guys to obviously ask questions, not just of me, but if you leave here and you think of things, have trusted resources that you can look into.